Okay, we're going to talk about drugs in the body. All right, so understanding what drugs are doing in the body and how they're interacting with our body processes is essential for safe and effective nursing care. So, being able to understand this is going to help you be able to anticipate um, what the therapeutic outcome is going to look like, knowing what you need to monitor for, being able to early identify if there are adverse reactions, prepare for side effects, and just make sure that it's doing what it's supposed to do and knowing how to take action, um, and anticipate, if things could go wrong. So, some of those terms are pharmacokinetics, is just how those drugs are moving through the body. We'll talk about those different processes. Pharmacodynamics is those chemical and physical effects of the drugs, and then those actions on the body. And then pharmacotherapeutics is how are we using those to prevent and treat diseases. All right, so pharmacokinetics is how it is moving. So kinetic is movement, right? So how the drugs are moving through the body, and then what is it doing to our body? Part of this, we'll talk about onset, peak, and duration. And all of that is going to be determined by absorption, which is it coming into the body, distribution, how it's moved into tissues, metabolization, how it's broken down so that it can be excreted, and then excretion is obviously removing it from the body. All right, so absorption, this progresses from the time it's administered, passing to the tissues until it's available for use by the body. So being absorbed. This can be by active or passive transport. The route of administration, the amount of blood flow, and the form of the drug, whether that be a pill, IV, IM, whatever, affects the absorption. So passive transport, there's no energy involved in this. Diffusion is how this happens from high to low to concentration. So examples of that are oral medications. Active transport requires cellular energy. So this is moving from lower to higher. So it's going to take more energy. And an example of this is us being able to absorb electrolytes. That happens through that active transport. Okay, so like I said, the form of the drug does affect how things are absorbed or how these meds are absorbed. Most oral medications are absorbed in our small intestine and then they're transported to the liver before they're circulated in the body. And so, therefore, if some portion of that is disrupted, the absorption is going to be different. So, for example, if a portion of our bowel is removed, there's less surface area, and then there's going to be a reduced time the drug is in the intestine, so it's not going to be absorbed as well. Um, it also, as I said, requires for the liver to metabolize the drug. So if there is some issue with the liver and it can't be metabolized correctly, then there could be the liver could metabolize too much of the drug, and so less is released in the circulation. A concept that is important to know in this is the first pass effect, which basically means it's metabolized, and then the function of it is lost. So the body isn't actually getting that because a portion of that medication is lost in that first pass through the liver. Um, so if that is the case, then they're going to need higher amounts of the drug to be effective because some of it is lost through that first pass. Okay. So the more blood flow, circulation, like I said, is another part of this. So the more blood flow there is, it improves that absorption, allowing it to be absorbed easier. If there's decreased blood flow, then that absorption is going to be decreased. So if it is absorbed more rapidly, if there is more blood flow, then the onset is going to be quicker, and then vice versa. Okay, so knowing those things, if your patient has some sort of liver impairment, if they have some sort of small bowel impairment, if they have decreased circulation, just depending on different conditions, then that is going to affect the absorption of the drugs, and doses may have to be modified either way. So pain and stress can also decrease absorption, and this is due to changes in blood flow or reduced peristalsis through our GI tract because of the autonomic nervous system. So our body, when we get that fight or flight, your body stops those non-essential processes, right? So fight or flight is triggered by stress. So that could be a lion is about to eat you. You're stressed. Your body says, oh God, we got to prioritize getting the heck out of here and protecting ourselves. Your body doesn't know the difference between being chased by a lion or you're in nursing school and have a lot going on, right? So stress is stress to the body. But when you're stressed, it decreases those non-essential or non-prioritized body functions. And so your GI tract is going to be lower on the totem pole, and so because of that, absorption can be um, diminished, or affected. So other things to consider are that combination with other drugs or foods can interfere with this. So some examples, high fat or solid foods can slow the emptying of the stomach to the intestines, and that is going to delay that absorption that normally occurs in the intestine. So here are some different forms of medications, and I think we've already talked about those. So distribution is how the drug is delivered to our tissues and body fluids. This is affected by blood flow, barriers, whether that be they're lipid soluble or water soluble, is it crossing the blood-brain barrier, and whether they're bound to proteins or not. If they are bound to proteins, then they are inactive, so that is going to affect that distribution. So metabolism is our body breaking down that drug so that it can be excreted by making it a more water-soluble form. So it can involve in converting it to inactive metabolites, where obviously that's not active, which is the most common, or by active metabolites, where they then exert their own action. Then they could either be further metabolized or excreted. And then another consideration is prodrugs, where what you take is inactive, but through that metabolization, then they become active. Okay, so the enzymes in the liver is the most common site for metabolization, but it also can occur in the plasma, the kidneys, or the intestinal membranes. Some drugs do inhibit or compete for enzyme metabolization, and so that can lead to an accumulation if those drugs are given together or make them inactive, or it increases your risk for toxicity or adverse reactions because those drugs aren't being broken down the way that they're supposed to. So therefore they are remaining in higher levels in the bloodstream, causing potentials for interactions or just harm, especially if you're taking additional doses. So therefore, things that can affect the liver circulation can affect metabolization. So heart failure, cirrhosis, liver disease, genetics also plays a role in this. Environmental factors like if the person smokes or if they're stressed. And then age is a huge consideration. In fact, everything that we are going to talk about will have considerations for children and for older adults. A general rule, because their metabolization is going to be affected, we are going to start low, so we're going to have low doses and go slow. We'll slowly increase it until that therapeutic effect is achieved. Excretion is the drug being eliminated. Most of the time, this is through urine via the kidneys, but also could be through the lungs, through respiration, sweat, salivary glands, mammary glands, skin, intestinal tract. This is important to consider because some drugs, if you are sweating them out or if you are nursing a child, those drugs can be excreted through that. So if it's something toxic, like let's say like a chemo drug, and it can come out through your sweat, if that potentially has reproductive harm or if that potentially hormones are another thing. If somebody is coming into contact with your sweat and hormones are being excreted through that, or if harmful chemicals are being excreted and people don't really know they're coming into contact with that, that could be a risk. So teaching patients if that is a potential is very important. um, Half-life is a term you'll hear. This is the time it takes for half of the original drug concentration to be eliminated from the body. Your book goes into calculations for this. Basically, there will be an interval, and that will be, half of that concentration, and then it continues in those intervals to be divided by half until it reaches zero. Okay? Most drugs, if they're given only one time, the concentration of that is completely eliminated after 4 to 5 half-lives. But if it's given at regular intervals, it's going to reach a steady state, excuse me. Um, so the rate of absorption, metabolism, can affect excretion. Onset, peak, and duration is some factors that you will hear in knowing how often you need to administer a medication, when to anticipate effects, when to know that it's no longer effective, and potential for it to interact with other drugs. So onset is when it is having those therapeutic effects. This can be affected by the route that it's administered and just how it's moving through the body. Peak is when it's the absorption rate equals the elimination rate. That doesn't necessarily mean the peak response. And then the duration of action is how long it has that therapeutic effect. So that's going to be important to consider for how frequent we need to give this medication, how long is it going to be effective, how long we could see effects. So especially if that's a harmful effect. If I give a drug and that it causes respiratory depression, and the patient is negatively impacted, I need to know how long that's going to be in effect, right? Especially if I'm given it with another drug that could cause the same thing. The therapeutic drug levels, this is measuring peak and trough. This is very important for making sure that drugs are effective, making sure that they are being excreted properly, and that the patient's receiving a therapeutic dose. This is especially important for medications that can have toxic effects. Okay, so that trough, they are measuring that when the drug is expected to be at its lowest. So that is going to be right before the next dose is administered. So I expect that it's really going to be gone, so that then I'm going to give them the other dose to keep it steady, right? So it should be at its lowest. If they measure that and it's not, then the interval of time, potentially they'll affect the dose, change the dose so that it can be effective. Some examples of drugs that we might check a peak and trough for are vancomycin. Another thing is loading dose, where we'll give them a higher initial dose so they get the full concentration sooner, and then adjust the dose from there. Okay, so digoxin and vancomycin are examples of drugs that may get a higher loading dose. So commonly, vancomycin, they'll write a prescription for that to be give 1,000 milligrams of vancomycin now, and then pharmacy to dose based on, peak and trough. Pharmacodynamics is those physiological or biochemical changes in the body, how they're being affected by drugs. So there's cellular interactions that occur between cell membrane enzymes and target receptors. So the drug effect is how the body's responding to that drug action. So the drugs can alter target cells' function by changing the chemical environment or interacting with receptors either in the cell or on the membrane. An example of that is agonist. So agonists are attracted to or have an affinity for the receptor and stimulate that receptor to produce that response, okay? The intrinsic activity is the ability of that drug to initiate the response after binding the receptor. Antagonists are also attracted to or have the affinity for the receptor, but they don't have that intrinsic activity. There's not going to be a response, okay? So those can be competitive or non-competitive. The non-competitive could be it's binding to the receptors, and no matter how much of that agonist there is, it's not going to have an effect, okay? The competitive, there is potential if you gave more of the agonist that you could have it could be activated, okay? It can be overcome. We'll talk about that more specifically when we get into different drugs, but students are commonly confused by these two terms. So agonist is making it happen. It's agging it on. It's going to make that work. It's doing what it's supposed to do more, I guess. Antagonist, when you think that it's it's blocking it, it's an inhibitor, okay? These are common things that students miss, so try to remember the difference between these two. So this can be non-selective, where they're acting on multiple receptors and causing widespread effects, or it can be selective, where it's specific receptors and specific effects. Potency is the amount of drug to produce that desired response. Therapeutic index is the relationship between those therapeutic effects and adverse or toxic effects. Margin of safety is just the ratio of the toxic dose to the effective dose. Okay, so if it has a narrow margin of safety, then there's going to be a very little window between what's effective and what's lethal. And then high, obviously, there's less risk of toxicity. Pharmacotherapeutics is how we use drugs to treat diseases or symptoms. So considerations in prescription of drugs is its effectiveness, its cost, and availability. So some factors in drug therapy, it depends on the severity, the urgency, and the prognosis. So some terms here are acute if the person is critically ill. Empiric is where we know that this works in this way just based off of like anecdotal experience versus scientific data. Maintenance are for chronic conditions like keeping them stable. Supplemental is providing what the body is missing. Supportive is it's not treating the cause, but it's protecting the body systems until that condition resolves or is maintained. And palliative is a switch in focus from treatment and healing to maintaining quality of life. And that's reserved for patients who have life-threatening conditions. So, selection of drug and how our body responds to it really is individualized. So, the comorbidities that a patient has, their overall health condition, how's their liver, how's their kidney, how's their cardiovascular function, their genetics, their immune status. Are they on other medications? Is there potential for interactions? Do they actively have an infection or some inflammatory process going on? What is their lifestyle? How old are they? What is their weight? What is their diet like? What is their gender? Are they actually taking the medication, and do they have the potential and intent to adhere to the prescription? what is their psychological status? What kind of environmental factors could affect the response to these drugs? Tolerance is just a decreased response to a drug over time, so the patient will require a larger dose to produce that same response. There's also drug dependence, where people develop a physical and psychological need for a medication. So the physical need can result in withdrawal symptoms. So alcohol or opioid medications can, if a person becomes dependent on those medications, can produce withdrawal symptoms if they're not, if they don't receive the drug. And then the psychological need, they take it to avoid discomfort or ease tension. So there are interactions that can occur when giving medications with other drugs or with food, and the more meds a person takes, the more risk they have for an interaction. It also is important to know that drugs can interfere with lab results and EKG, so we need to monitor those depending on what the drugs are. And drugs that are given together, or what these effects can occur, could be all of these things that are listed below. So if they're taken together, then they could make the same action happen, which could make it, increase, which could be what you want, or that could be a concern. Or it can block the action of another drug, so they wouldn't need to be given together. Alcohol, milk, and protein can affect stomach acidity and increase the breakdown of some drugs, or others, it could block their absorption. And so it may be important to avoid taking those things together. It really just depends. Antacids is another thing that's very common, because stomach acid contributes to us breaking down or being able to absorb the drug. And so if we're stopping the stomach acid, we're affecting that absorption. So like I said, foods can affect this. They potentially can cause toxic interactions. Grapefruit juice is something you will see in here with several drugs, because it can stop the metabolization of those drugs and lead to toxic levels. General statement: if you see grapefruit juice, don't do it. That usually is either going to be the answer to avoid it, or not the answer if we're saying it's okay to take it with it. Some drugs can stimulate enzyme production and increase metabolic rates. Some can impair vitamin mineral absorption. These interactions can produce a desired effect, which is what we're wanting, the therapeutic response. Side effect, that is the expected response. That can be therapeutic or non-therapeutic, but it's not necessarily harmful. I know that it's going to happen, but it's not deadly, I guess. For instance, if I am taking morphine, I expect that that's going to make me sedated, right? That would be a side effect. That isn't necessarily what I'm giving it for. I'm giving it for pain, which would be the desired effect for pain control. The side effect would be drowsiness. Adverse effect would be undesirable or harmful. Example, morphine. If it causes respiratory depression, that could be an adverse effect, especially if that is extreme, right? Iatrogenic is where this can mimic pathological disorders. So if a person takes a steroid, it can make their blood sugar go up, and that could look like diabetes or hyperglycemia, right? But not necessarily, they don't have diabetes. If they stop the steroid, that's going to go away, okay?